just a few years ago, a lot of the stroke that today walk out of the hospital would have had devastating outcome literally just a few years ago when I was in residency.
Dr. Marc Babi in the great state of Florida, the Mecca at Shands Hospital, neurocritical care program director, neurologist extraordinaire. How you doing, my friend?
Pretty good. Thank you. Thank you very much for having me here. Pretty excited, at least virtually.
Virtually, yes. I'm excited to chat with you. Neurology and neurocritical care are very important in the ICU world, taking care of patients who suffer from either traumatic brain injuries or from strokes and hemorrhages and all of those kinds of things. Talk about for a minute kind of what the world of neurocritical care looks like for you.
No, totally. And literally that word was 3 minutes ago because I'm the ICU attending for the night tonight. So I have my resident and fellow working really hard. So what we see in the neuro-intensive care unit is a mix of neurological and neurosurgical emergencies. We see a lot of stroke in a broad category sense. So a lot of ischemic stroke that needs surgical intervention, mechanical thrombectomy or thrombolytic. We see a lot of brain bleed, subarachnoid hemorrhage, intra-parenchymal hemorrhage. Some are surgical that our surgeon operate on, either through an open craniotomy, like taking a piece of the skull out and taking the blood out, or through a minimally invasive surgery, where now we go like with small introducers, small needles, and take out the blood. We also see a lot of trauma cases, traumatic brain injury and traumatic spinal cord injury. I would say roughly a quarter of my neurointensive care unit are brain and spine trauma. So is a young, previously healthy individual who got involved in motor vehicle accident, ATV accident. Even last week, I think, or the week prior, I had a surfing accident, a young individual who rolled over their surfboard and ended up having both a head and spine cord injury. Wow. And then, of course, we get elderly patients, state of Florida being a state where we have a lot of retirees. We get elderly individuals falling and then hitting their head, ending up with a subdural or epidural hematoma, especially those who are on aspirin or other blood thinner. They fall down and then they end up with brain bleed. Yeah. We also get non-surgical neurological emergency like seizure and status epilepticus, protracted seizure. We get brain infection, meningitis, and encephalitis. And most recently, what we've been taking in our neuro ICU are a lot of COVID-related neurological complication. So right now we're in the middle of a pandemic, but any patient who have COVID and neurological complication, we admit them to the neurointensive care unit. So we're starting to see a lot of stroke, a lot of brain swelling, brain edema, vasculitis, inflammation of blood vessel of the brain. We see a lot of those. So in summary, a lot of very sick patients with severe brain and spinal cord injuries and disorders. That's kind of a broad overview of patient population we see.
Wow. So my wife's a neurologist, and kind of breaking news to the pre-med world is she has stopped her clinical practice. She was practicing sports neurology, concussion, TBI, and it's a lot of just bad outcomes that with patients who never really get better. In your world, in a neuro-intensive care unit, how often are patients getting better and you're sending them home and everyone's happy?
Right. So as I alluded to, we see a lot of very sick patients, but the advance in medicine and technology that we've had, not just over the last 10 years, but just over the last few years, has been phenomenal, has been amazing. I mean, just a few years ago, a lot of the stroke that today walk out of the hospital would have had devastating outcome literally just a few years ago when I was in residency. So I finished residency 8 years ago, and it now is vastly different what we're practicing. So in summary, we've seen tremendous advancement in technology. I mean, every day there are new clinical trial and research trial, new medication that comes up. So we've changed outcome in a big part, but also nonetheless, there are still devastating neurological disorders, especially those related to post-cardiac arrest or massive trauma to the brain, where there really not a whole lot we can do medically for those patients. But for me, a part that is extremely gratifying is having that privilege, that honor to sit down with family and navigate them or help them navigate through those tough decisions and end-of-life decisions. And I see it for me from my angle of someone who understands the medical physiology, et cetera, versus the family. Of course, they see it from the angle of they've known a patient for a lifetime. They're meeting a patient for one day only or a few hours, but with a deep understanding of the brain physiology, we can come to a common ground of what would be in the best interest of the patient, based on their family, who are now their surrogate decision makers, since obviously those patients cannot make their own decision when they're comatose or on mechanical ventilation. So that part, as much as it sounds, can be taxing, but also is very rewarding, very gratifying.
Yeah. It's interesting. It's funny. You talked about mechanical ventilators, and we picture ECMO and stuff for lungs and hearts. There's no ECMO equivalent for the brain, unfortunately. Unfortunately. So one of our favorite questions here for e-shadowing is, what is bread and butter for a neuro-intensivist?
So bread and butter, as in we'll do a lot of hybrid surgical and critical care procedure. So obviously, any neuro-intensivist, for the most part, are of neurology background, but we also have some of anesthesiology background, some of neurosurgery background, or emergency medicine. I'll give you a glimpse. I have 6 fellows per year. 3 of them are of neurology background. 1 of them completed neurosurgery. 1 has done internal medicine, and 1 of emergency medicine. So at least deep understanding of neuroanatomy. And then we do a lot of both critical care procedure and more specialized interventional or neurosurgical procedures. So intubation, airway management, central venous cannulation, like internal jugular, central line placement, subclavian placement, arterial line placement, chest tubes if needed, tracheostomy for those who are proficient in tracheostomy, or percutaneous gastrotomy, so feeding tubes to the stomach, semi-permanent, EVD placement, external ventricular drain. Some of us are trained in placing those, or intracranial pressure monitors, EEG interpretation, electroencephalogram interpretation, and trace cranial Doppler. So those are some of the common skill sets that a majority of intensivists or neuro-intensivists are proficient with.
Yeah. Interesting. And just for clarification for some of the students asking, you're not the neurosurgeon who's taking the patient back to the operating room, correct?
Correct. So I'm not a neurosurgeon per training. I did neurology and then neurocritical care. My medical management part involved the perioperative and immediately post-operative part. So we'll go through a scenario. A patient has a large brain tumor with a lot of brain swelling. We will have kind of a debriefing, me and the neurosurgeon, about what their plan, what the anticipated surgical process. But then a surgeon will be directly involved with the surgical aspect in the OR. I'm not involved in the OR. The immediate post-operative course, managing that patient. They have brain swelling. They need procedure subsequently in their brain, like a line, a drain, an EVG. That I will take care of that part. I will handle that part in the ICU. If that patient is unable to breathe on their own, need a breathing tube, I will take care of that part, both procedurally and medically. I'll address that.
Yeah. Awesome. So the training path to become a neurointensivist, you mentioned there are several different paths to end up in the ICU. For you specifically, medical school, 4 years neurology residency, including that 1 year internship typically. And then what does the fellowship look like for you?
No, total. So the fellowship for neurocritical care is either 1 year or 2 year, depending on the training or the prior training background. So right now, the accreditation body of neurocritical care is transitioning from UCNS, United Council of Neurological Specialty, to ABPN, the American Board of Neurology, and is shifting to ACGME. That transition is taking place this year. So the board qualification is that for an individual or a graduate who has completed training in neurology, internal medicine, anesthesiology, or emergency medicine, the duration of training has to be a minimum of 24 months or 2 years of training. Out of those 2 year fellows will spend a bulk of their time in the neurointensive care unit. So out of those 2 years, they spend about 12 to 14 months in the neurointensive care unit, and another 6 months of other subspecialty critical care training. For our fellows here, we'll spend about 13 months in neuro ICU, 2 months in the trauma ICU, 2 months in the medical ICU, and 2 months in the cardiothoracic and ECMO ICU, and another 3 to 4 months of elective time. If a trainee has completed neurosurgical training or has done prior critical care fellowship training, like critical care medicine or anesthesiology critical care or surgical or trauma critical care, then the neurocritical care training become 1 year in duration, so 12 months track duration, on the premise that such a trainee has prior general critical care, subspecialty critical care training. For the 1 year track, a trainee would spend about 8 to 9 months in the neurointensive care unit, and then another 3 months of elective time. So 1 year track, the majority of their time is in the neuro-intensive care unit, and then a couple of weeks in other subspecialty units.
Yeah. Imposter syndrome is something that lots of students deal with on every step of this journey, whether it's the first day of medical school, first day of internship, or first day of clinicals in medical school. How do you deal with the fact that there are very sick people depending on you for their life?
Totally. So when I see patients or interact with their family, as much as, of course, naturally, because we're all human, it may seem that naturally we may form a bond, an attachment to it. You really try to isolate that, because your role as a physician taking care of those very sick patients, you want to be very neutral as it comes to specific emotional attachment or reaction. My role is to provide the most appropriate evidence-based clinical care without any biases, and biases will come when you start developing that one-to-one connection. So the point is that you want to treat them according to the most recent evidence-based guideline, procedure, protocol, literature, and you want to maintain that objectivity and that neutrality, and appraise any new data that comes up, any new evidence. If patient condition deteriorate, then look at the new fact, the new data that comes up, or new study, and go from there. And I think following that principle helped me a lot across the many years, seeing a lot of sick patient and taking care of a lot of sick patient and in the ICU. Yeah.
So let's talk about a case. I think you said you'd love to talk through a case. We can bring some students up if you want to ask them some questions. Does that sound good?
Totally.
All right. So I'm going to clear out everyone here. If you want to come on and answer some questions about a case presentation, let's raise your hand and we'll get you on live with Dr. Babi. All right. So got one.
There's one thing I didn't talk about it yet, but it's about life balance, life-work balance. It's something I always preach to my trainees, my resident, fellow, and students. It's really important in general to maintain that healthy work-life balance. Any advice, I always say work is going to take a really big chunk of your lifetime. And of course, you have to come to work and enjoy and be grateful to what you do. But also, you don't want to mix up work with your personal life. It's also really important to maintain that healthy outlet. Do something that you really cherish, whether it's a sport, art, travel, whatsoever. For me, my venue is in outdoors. I do a lot of outdoor free diving. I love free diving, spearfishing, hunting, traveling. That's my venue. Some who may live in the mountains, skiing outdoor, but it's something I always preach. You really want to maintain that healthy lifestyle balance, because work is going to take a huge chunk of anyone's lifetime.
Yeah, I love it. Very important. All right, let's do a little case presentation. We got 3 students here. All right. What you got for it?
Hey, all right. So case presentation. For me, some people ask me, all right, what are some of the toughest cases? I will say that some of the most challenging cases are what we call the bloody mess. And the bloody mess, in a sense, as the name implies, are the penetrating trauma to the brain, gunshot wound trauma to the brain, or open skull fracture to the brain. So once in a while, we get gunshot wound trauma to the brain. Typically, those are generally healthier or previously healthy individual, either homicide or suicide related. It's very challenging. In general speaking, medically or ballistic injuries, if a patient has a through-and-through gunshot wound, through-and-through mean from one side to the other side, mortality is extremely high. Typically, it's about 90%, 95%. And the problem is that you'll see those patients bleeding from their nose, from their eyes, and bleeding from the side of the skull. There's really nothing we can do surgically. I'll ask my resident, just wrap the patient head, make them presentable, have the family say their goodbye, because there is otherwise really nothing we can do. And typically such patient will go in a state of generalized shock, because when the brain is so injured, the coagulation cascades, so the coagulation or the clotting factor in our bloodstream, which is a tightly intricate balance, but that goes out of whack. So patients start bleeding everywhere, not just from their eyes and mouths, but from every orifice in their body. So they see bleeding from the rectal, from the urethra, and that's what we call the bloody mess. It can get really challenging, and it happened very quickly. So that's some of the more challenging cases. Unfortunately, we see those every few weeks.
Okay. So let's talk through one of those cases. What as the neurocritical care doc, the patient comes in and is in that state. Let's ask these students kind of what their thought is in terms of stabilizing a patient or what they want to do with the patient. What do you think? Should we ask them some questions like that?
Yeah.
Okay, go ahead. What do you want to ask them?
Yeah, I mean, if you came across a case that you perceive, or medically you don't have a whole lot of option to medically salvage a patient or get them to a better state, how would you approach that scenario? What would you do, at least from a family angle, and how would you approach it for an end-of-life catastrophic brain injury?
Daniel, you want to tackle that one?
You said that they're bleeding out from a lot of different places in their body, so I would think that would be the first thing to address so that they don't lose too much blood and go into shock or something like that.
All right, yeah, fair. Absolutely. I mean, of course, bleeding control in any case of trauma is extremely important. Generally speaking, through the brain, there is not a whole lot of blood we can lose until it causes what we call hemorrhagic shock, like massive amount of, because as you know, the skull itself creates a fixed volume. So by the time a patient loses quite a bit of blood in the brain, the damage that occurs to the brain is so extensive itself. But the amount of blood is not significant to cause like a state of severe shock, unless, of course, they're bleeding elsewhere, as you say, like they're bleeding from another cavity, which, of course, you want to control bleeding.
Okay. What about you, Amy?
I would say one thing that would be kind of important is just to be completely honest. Can you hear me okay?
Yep.
I hear you. Hear you very well, Amy.
Just be completely honest with the family as to what the outcomes are going to be and not give them any false hope. If it were my family member, I would want to know, even if the outcome is eventual death, just to know and not have any false hope. That would be probably one of the main things that I would think about, is just being, in this case, brutally honest with what's actually going on and what's going to happen in the future.
Amy, you're absolutely correct. So I've had a lot of family meetings in my career, and my family meeting are, as I said, really an honor and privilege to do that, because I'm here meeting with a family I've never known before, but I'm delivering the most serious news about their loved one that they've known for a lifetime, for a family I don't know yet, and they've given me that privilege of taking care of their loved one. So with that come a lot of responsibility and ethics. And my responsibility, my commitment toward the patient and family, to deliver a very honest and direct message to them based, of course, on the medical fact, not just based on what I feel or I think, of course, based on the formulation of my medical judgment, based on scientific and medical fact. And with that, Amy, as you said, you have to be very honest. And sometimes you'll have family who are not happy with the answer you give them, because they will want to hear for a better outcome, right? They're being hopeful something will happen. And I've had families scream, yell, or sometimes pass out when I had to deliver really bad news. But you have to take that, of course, with honor and dignity, and everyone deserves an honest judgment answer, and be very ethical in how you deliver that news, and very honest.
Yeah. Dr. Babi, talk for a second. As we're going through this pandemic, we see a huge anti-science movement, it seems like. How much of that are you seeing in family meetings?
We see to a certain extent. Unfortunately, it is a problem, right? Because it's a problem not just among family members, but unfortunately among some educated folks as well, where now with the extent of internet, everyone can get any potential source of information. It doesn't mean that information is factual or truthful. So we've seen that a lot in the pandemic, where we had to undo a lot of the misinformation. So the misinformation, not just related, for example, to COVID-19, which of course we see a lot of misinformation, was related to the actual COVID virus or coronavirus, or the vaccine itself, or complication, versus for us, the medical community, I deal with it every day. I see it before my eyes. But one of the major things I used to see a lot, even pre-pandemic, is relating brain death determination, the concept of brain death and what it means, brain death. So brain death, for those who are not familiar with, it's both a medical and a legal diagnosis. It's a medical diagnosis when you have irreversible, or the patient has irreversible function of the brain and brainstem. There's something catastrophic, really bad that happened to the brain, a massive stroke, massive trauma, that there's so much swelling of the brain that there's no longer blood flowing to the brain and brainstem. It stops. So that's the medical part. Legally, in the United States and most of the Western Hemisphere, if a patient is diagnosed with brain death, it is equivalent to death. It is a type of diagnosis where us as physician who diagnose formally the patient with brain death issues a death certificate. That is no longer for the family to make the decision about what they call pulling the plug or turning off artificial support. That's very different. Pulling the plug is kind of late term, but what it means like mechanical ventilation or vasopressor medication that support the heart. Unfortunately, when we deliver such bad news, we have had a lot of misinformed family who tells us, well, they've heard on the news or they read on the internet that patient have been brain dead for many weeks or months, and then they recovered, they woke up. And then you go even online, if you Google that, you may come across those cases. Unfortunately, there is a lot of misinformation about such diagnosis. And myself and one of my colleagues, we wrote an editorial about why there is such misinformation about that diagnosis. For example, comatose patients who were in a coma but not brain dead were mislabeled as brain dead patient. Or the term of brain death was loosely used or associated with a devastating brain injury like a coma state or a persistent vegetative state, which is a separate category, but it's very different than brain death. So those are some of the misinformation that we often come across. And now, of course, in the era of COVID-19 pandemic, we're seeing a whole different set of challenges, etc. And as I said, we're all human. It's natural for human to have biases, right? And unfortunately, we've been seeing a lot of biases across the political spectrum. I'm not going to touch that much deep, but we see that, unfortunately, and it does potentially affect medical care and how medical information are perceived as well.
Yeah. Okay. All right. What do we want to ask our next two suckers here? I mean, students. We got Michael and Lucas. What can we ask them about a standard patient that you see?
Yeah, so let's say you are the resident or the fellow, you're doing a procedure to the patient, everything is going smooth until something horrendously happened, right? Patient stop bleeding, or with your procedure, you hit an area of the brain that stop bleeding from their brain, or you're putting a line in their deep vein, and then your line goes too deep, or as you're putting it, you end up puncturing the lung, and there is blood everywhere, your patient become unstable. How would you approach that? And by the way, those are real scenarios. It has happened to my trainees, to people I supervise and train.
Yeah. Michael, what do you think?
So I think in that scenario, can you hear me? Okay.
Yeah.
In that scenario, that would probably be what they call a code or a code blue on the floor. And that person could either be taken by another physician, someone who's specialized in emergency medicine and emergency surgery, and try to best stabilize that patient. So you could probably work with that patient as long as you could, and then work alongside that other physician who's going to come in as a specialty surgeon and try to find out where the bleed is.
Yeah, no, great answer. Absolutely. So, of course, any procedure comes with a risk, which is why always for any physician who will perform a procedure, we try to categorize what the urgency of performing that procedure. Is it elective? Elective, can it wait? Is it urgent? It need to happen, but may not need to happen this moment. Or is it emergent, where your patient life is depending on this? So with that comes something called informed consent. So generally speaking, for the most part, you want to also obtain consent for the patient. Explain to them absolutely what the indication of the procedure and what the risk benefit, because that's the first question you're going to get asked when something goes wrong or you have a complication of procedure. What was your consent and what was the indication of procedure? The next thing, anyone performing procedure need to be also proficient. So of course, in teaching hospital where we have resident and fellow, they go under supervised training where they initially mentor by an attending physician, someone who's done it. And then as they get more proficient, we give them more and more autonomy to do it. But the key, of course, any resident performing such procedure need to be proficient, have watch videos, have gone through workshop, have seen lecture, have seen someone perform it, kind of that gradual learning phase. And then, of course, when they do the procedure, any learner needs to recognize their limitation. If they don't know what they're doing, they have to stop. And I always say that to a learner, to a trainee. If you don't know what you're doing, remember, you're not performing on a mannequin. You have a human life. Whether you're doing something in a patient neck or a patient brain, you have a human life. So if you don't know, stop and ask for help. And it's okay to ask for help. It's not bad, or it's not an ego, because it's not about you. There is a human. It's about your patient. And then, of course, if a complication happened, which it will happen, I said if a complication never happened in your career, you really haven't done enough procedure. Now, not every procedure needs to come with a complication, because then there's a problem with that physician, right? If every procedure goes wrong. But some complication will happen, and there is an accepted rate. Then ask for help. If a complication happened, recognize, acknowledge it, ask for help your patient, and then be honest to the patient or their family. Tell them what happened. Don't try to cover things up. Tell them that things happen, and apologize if it's appropriate, and acknowledge it, and of course fix it. Don't just tell them, but salvage, clean up the mess that you've caused.
Do you think we're past the time where a lot of people were afraid to have doctors apologize, because there was this idea that if you apologize, you're admitting fault? And I think the legal world has said, no, like, you can apologize without admitting fault. Are hospitals on board with that? Are they okay with you apologizing?
So state by state. So great point. So what Dr. Gray suggests, like, how do you do with the apology? So if you look at litigation, and that's something I'm fairly interested on. I sit on the Law and Malpractice Committee at my current institution. I also sit on the Ethics and UF Regulation and Compliance. So different states have different regulation in terms of malpractice. The malpractice process is pretty complex, of what constitutes from a medical mistake or medical error to a malpractice, because not every medical error can amount to a malpractice. Now, every state have different rules and regulation as it comes to apology. Some states, for example, I did my residency in the state of Vermont, great state of Vermont, at the University of Vermont. In that state, apology can be to a patient or family. It is considered that you admit guilt and can be admitted in a court. State of Florida and state of Georgia have no law about saying sorry to the patients, case by case, and nonetheless also become a little bit more complex. For example, as I'm practicing at the University of Florida, which is considered a state university. So state university means we belong to the state, we get funded by taxpayer. So you are under sovereign immunity as an individual. In most cases, you will not be named individually, of course, unless you were grossly negligent in your case. But let's say a medical error happened, patient or patient family were angry at you or upset at the medical error, they want to sue you. For the most part, you're not going to be named individual. It's going to be the plaintiff, the family, or their representative versus the state of Florida. So in most of these cases, saying sorry to the patient family is actually pretty good. It's expression of empathy, and sometimes a lot, like, being on the side of the patient, showing empathy to them and admitting really goes a long way. And most of the time, family will not sue you. So having that excellent rapport with patient and their family will protect you a lot of the time.
Yeah. All right, let's get Lucas a question, then we'll bring some students on to ask the questions. What should we ask Lucas? Give him the hardest one we got.
Yeah, Lucas, the hardest one. Let's say you have one single bed left in your intensive care unit, and you have two very sick patients in the ER. How are you going to triage? And that's something that Dr. Gray, as an ER physician, and myself, as an ICU physician, we get faced all the time, right? We have limited resource, and we have a lot of sick patients. How do you handle a situation with a limited resource? And now we've seen it even more with COVID.
just to clarify, I'm not an emergency medicine physician. I was a flight surgeon in the Air Force, but yeah, triaging is a part of medicine, period.
Okay, so two patients showed up that would need the ICU, but there's only one spot.
There's only one spot, yeah.
Yep. So like you're saying with triage, I guess you'd have to go by level of acuity, and maybe, I don't know, I'm thinking, at your facility, there might only be, one ICU room, but there might be another part that might be able to have some of those capabilities until they're transferred. So I'd maybe consider, which ones might need a specific procedure or specific observation at that point, and maybe who could handle a little bit more time until they could transfer them, or, get staff to, man some other section.
So let me make it a little bit harder.
Yeah.
Both of those patients have very similar presentation. Both of them have stroke. One of them is a homeless patient. One of them is a VIP. And those are real scenarios. So, one of them is a homeless, one of them is a VIP. And they have very similar problem. Both of them have bad stroke in the ER. By the way, those are weird cases I've come across.
I give this exact situation during practice interviews with students.
They both have similar. So then I'm thinking they both would have similar outcomes. Otherwise, I would, say, who could benefit more. But if similar case, similar outcomes, I think you might just have to go with who came first, who was there the longest. Then maybe their condition would be a little more progressed than the other.
Both in at the same exact time.
Well, you need to admit one. Inaction would lead to terrible consequences for both them. So I would guess I would just pick the first one that I saw or came to me and admit them, and then rely on coworkers to attend to the other patient and organize that scenario, recognizing I can only do one thing at a time.
No, great answer. That's when sometimes you may have to ask another doctor to help, specifically like ethics doctor. As I said, I also sit on the ethics committee for the hospital. What do you do under the principle of resource allocation when you have scarce resources, which is something we've been seeing right now in the era of COVID, right? You have a lot of very sick patients with COVID, and you want to as much as help everyone, but you have set number of hospital bed that you can take care of patient, and you have set number of staff, nurses, respiratory therapists, physician, etc. So under the principle of resource allocation, you may have to make, unfortunately, that really tough call about which patient potentially may have a better outcome and a better outcome for subsequent hospital care. Because as you know, a lot of patient long-term recovery or outcome play a huge role in terms of what's their potential post-hospitalization course in terms of resource, rehabilitation, and so forth. So for the patient who may have a better chance for both in-hospital and post-hospital recovery, those are probably the patient you're going to have to make, unfortunately, the tough call to admit and bump over the other patient. That's unfortunately the tough reality in the context of limited resource and resource allocation.
Yeah. Definitely a tough situation. Thanks, Michael. Thanks, Lucas. All right, if you want to come on and ask some questions now, we're done pimping. It's funny how you set that up, because I do the exact same thing. You're a rural emergency medicine physician. Ambulance is coming in with two patients, same kind of level of acuity. Both need care or they're going to die. One's a homeless heroin addict. The other is a wealthy philanthropist in the area. One is 20, one is 60. How do you how do you figure that out? And just for everyone watching, like, a lot of times there's no right answer to it. The ethics committee can come up with something, and that's always a good answer. Is go to the ethics committee. You're never alone in the hospital, typically. So going and asking for help. But the thought process behind, and Lucas had some good thoughts behind his answer there. So Alex Roy, hello there.
Hello. How are you?
I'm good. Dr. Babi, how are you?
Good. Thank you. Thank you very much for having me.
All right. Alex, I saw your question earlier. Do you have CP?
I do.
Okay. All right. What's going on? What can you what question do you have?
I was asking like can a person with CP do this specialty? Or will it be hard for them?
Yeah. So the question, Alex, if I heard you correctly, can someone who has cerebral palsy pursue that specialty, or would it be difficult?
Yes.
So, okay. Yeah. So of course, to pursue the specialty of neurocritical care, one will have to go through the medical school training. So medical school, of course, had a certain admission process, and then following medical school, there is a neurology residency or anesthesiology of emergency medicine. So most of those specialty training would take 3 to 4 years in duration, depending on the specialty. And of course, residency program have different threshold for admission. So they will look at USMLE score, letter of recommendation, community service, GPA score. So they look at each applicant holistically. And of course, I do that because I sit in also our residency application review. So, and for example, we take every year 8 neurology residents at the University of Florida. we get an average of 800 to 900 applications. So it's a very competitive process through residency. As I said, we look collectively at all factor grades through medical school, letter of recommendation, community service, USMLE or STEP score or MCAT score. So USMLE are through med school, and then STEP score. And then subsequently, one will have to do fellowship. Fellowship is an additional training after residency. So the point is that it's a long training process. It's pretty rigorous, where there are a lot of factors involved. And in general, all university and all hospital are under ADA, so American with Disability Act, which of course no one would discriminate an individual for admission process based on disability or other factors. So that's of course illegal. But the admission process, of course, is dependent on a lot of the other factors that I mentioned. Does that answer your question?
Oh, I muted you, Alex. Unmute yourself.
Thank you very much.
Of course, you're welcome, Alex.
Yeah. And neurocritical care is an interesting specialty. Even though it's a medical subspecialty, there's a lot of procedures in the ICU, and so someone with CP or any other disability is going to have to prove, unfortunately, that they can do the procedures necessary to be that type of physician.
Exactly. Yeah, exactly. And that may take a different track approach. I mean, there is an office for AD under most university where they may make different type of accommodation or a specific track. And specifically, I say that because we've had, for example, residents or fellows in specialty training who've had specific disability or impediment, again, case-by-case scenario.
Yeah.
But the point is that for the process of training or admission, it's not just one factor. There are a multitude of factors that are involved.
Yeah. Good question. Good answer. Sawith.
Hi, can you hear me?
I hear you.
Okay, so when you work in the neurocritical care, like ICU, you obviously have quite a few palliative patients, right?
Yeah.
And so when it comes to palliative care patients, like how do you go about the whole discussion of advanced care planning?
Yeah,
like, are you professionally trained? Like I trained for that during medical school, like how you bring up the conversation, because there's various factors that factor in. For example, if the person is from a cultural background where like they don't like to talk about death because they don't want to put it out there, you know, and like there's various factors that affect that whole discussion. So yeah, I was just wondering, does medical school prepare you for that?
No, great question. So the question that's always asked is, how do you approach end-of-life discussion and palliative care and tough conversation? This actually boasts professional training that trainees go through in med school and then residency, and then, of course, through fellowship training. They rotate on different services, palliative care, they take course lesson, and then it's an ongoing longitudinal training as you through your professional career as you deal with end-of-life discussion, goals of care. I'll give you an example, a glimpse. Today, I've been working in the hospital, taking care of critically ill patient. Probably I saw 35 to 40 patients. I've had at least 20 family discussion in person, one-to-one family discussion. Some different aspects. Some were delivering bad news. Some were sharing better news. Some were about plan of care, what we should do. Some about surgical planning. So it is something that comes as well with training and with experiences with time. So again, to answer, post-professional training throughout residency and fellowship, and then when you become a full-fledged physician, it's an ongoing process throughout your career.
Okay, amazing. Thank you.
Good question.
You're welcome.
Anish.
All right, so I had a simple question. So what is the difference between epilepsy and stroke, and would you treat them differently regarding medicine, and which one takes priority when both are admitted at the same time?
Yeah, well, multiple questions in one. Yeah. So epilepsy is seizure. Yeah, epilepsy is seizure, basically. So seizure, it's a single convulsive event, and then when a patient has recurrent seizure event, they may be diagnosed with epilepsy, which is a disorder. So epilepsy is a disorder characterized with recurrent seizure. Stroke, it's a cerebral vascular disorder. So stroke, it's a broad term category, which can apply to you. And you have three categories of stroke. Ischemic stroke, which means when patient have blocked vessel in the brain. Is it blocked vessel because plaque have been building up, or because a clot came from elsewhere and blocked the flow? There are small vessels that are blocked. Or bleeding in the brain, we call that intraparenchymal hemorrhage, hemorrhagic stroke, or bleeding around the brain, subarachnoid hemorrhage. So that's the type of stroke. Now, sometime patient after having a stroke develop epilepsy, right? Because stroke leaves a scar in the brain, and then they develop seizure, recurrent seizure, which is epilepsy. So again, the treatment is vastly different. There is some overlap, but the treatment is vastly different. And then for the second part, if you have two patients, one with stroke, one with epilepsy, which patient would you take priority in admitting them, especially if you have limited bed resource? It, again, depend on a lot of factors like comorbidities. Comorbidity means what other medical issue they have, what treatment approach I have. For example, if it's a massive, devastating stroke with no chance of recovery versus someone who's had really bad seizure, potentially we can treat them and recover. Or we may bump the patient with seizure, take care ahead of them because that's a patient that I can help. Versus if, however, on the other way around, if I have a patient with acute stroke that I can treat and make a big outcome difference, which we can see that, then I may bump that patient before the seizure patient, while the seizure patient waits in the ER for several hours until we are able to make a bed for that patient. So case by case scenario.
All right, thank you.
You're welcome.
Interesting question. Thanks, Anish. City. CD? How do you say that? Unmute. Unmute. 20 months into a pandemic, you got to know how to unmute yourself.
That's right.
That's funny. They were unmuted for a second.
Unmuted now?
There you are.
You're
Hello.
unmuted. Hello.
Okay, great. Thank you. So, and yeah, you said it perfectly. It's Sydney. So, one of my question was, after, you're done with the day and you go home, how do you deal, I guess, with kind of coping with those emotions if it's like, you lost a patient, or not even if you lost a patient, but let's say, especially with, given the pandemic, you're dealing with very sick patients. I guess, how do you deal with the fact, or the idea that you can't save everyone, especially as like you become older and you start to see these more cases? I guess, how do you prevent that burnout?
Yeah, so, and you said it, so burnout is a big problem among patients who work in tough specialties. So a lot of the surgical specialty and critical care subspecialties have very high rate of burnout. I think recently, unfortunately, they made a survey, and I think neurocritical care followed by spine orthopedic surgeon had the highest rate of burnout. So the key is that you really want to have a venue out of work, something you do that really makes you happy, whether it's sports, outdoors, arts, culinary scene, whatsoever. So I do a lot of outdoor activity. I do a lot of diving. I do a lot of outdoors. That's kind of my thing to do. I have two little kids as well who are the joy of my life, two babies, 4-year-old and 7-year-old. So as you can imagine, they keep me very busy at home as well with family events. And you try to really separate work event from your personal event. You try as much not to bring things from work to your home and then carry it to your family as much as possible. Now, of course, that's easier said than done because we're all human, right? Sometimes you have just a bad day and you're going to go through it as usual. But of course, with experience, the more you've seen patient, the more you get experience, you become more and more, I'd say like aware and you appraise those situations a little bit differently. And also that really helped me at work as well. I try not to have emotional attachment with patient as much as I can, because again, my role is to deliver a medical service for those patients based on my medical skill and expertise, right? You don't want to get emotionally attached with the patient. You want to deliver the best care possible factually, based on scientific evidence, based on guidelines, based on literature, not based because on emotion. Once you start getting emotional reactivity, that's where medical error can happen.
Good thoughts. Thanks, Siddhi.
Yeah.
Thank you so much.
You're welcome.
All right, Zara.
Hello. How are you guys?
Hi, Zara. Good.
So my question is that I was wondering, what is it about neurocritical care that you fell in love with? Like, what aspects that differ from other specialties that drew you into neurocritical care?
Yeah, so it goes back to, so in med school, in my last year of med school, when applying to residency, I was really drawn to one of the three fields that I thought I would go into, either emergency medicine, surgery, or neurology. I really fell in love with the brain. I mean, it's fascinating, a lot of things. I also liked surgery. It's because I'm proceduralist, I like to do procedure, and also emergency medicine, that fast pace. So ultimately I ended up choosing neurology as a residency. And as I rotated through the different neurology services during my residency, I realized the world of neurology is so vast. So, I mean, an outpatient neurologist dealing with headache and movement disorder or dementia is vastly different than what I do. Acute care neurology is very, very different. And then combining what I like from surgical procedure to emergency or acute care, I really found neurocritical care kind of the best of both worlds. Now, I've been a full-fledged neuro-intensivist post-fellowship, so post-residency and then fellowship for about almost 6 years now. And I love it. I mean, every day I learn something new, and it's a great field. And looking in hindsight, I don't regret a single minute of having made that decision.
That's great. Thank you so much.
You're welcome.
So, emergency medicine, a surgical subspecialty, neurocritical care, all very, it seemed like adrenaline junkie type field. Kind of going back to the earlier question that I had about like having that confidence that you can do those things. Like, is that something you're just born with, or is that a skill or a trait that you've seen residents coming in who maybe necessarily don't have those skills, or the fellows that you see as well? Do they gain that confidence over time?
So I've seen both. A great question. So I've seen both. I've seen both like a type of personality, kind of like an A type of personality, people who are doer. You have to make quick decision. You have to be confident. Of course, you have to be confident, but not cocky confident or arrogant, because there are patients, there are human life. And you don't want to make a rushed, arrogant decision that will affect the patient life. And then it's a natural skill set as well. So we also have some of our fellows and trainees that are on the really quiet side, but they're extremely skilled. They're quite doer as well, very skilled. And then over time, as they become proficient and confident, they build that efficiency and proficiency. So both, it's a learned process and then an innate ability, a personality type.
Nice. Okay. Thanks, Zara. All right. 2 more questions here. Elias, how you say that?
Can you hear me?
Yep.
Yeah, we hear you, Elias.
Yeah. It's pronounced Elias, but
Elias.
it's okay.
All right.
Yep.
Yeah.
I just had a quick question going back. You were talking about like the potential errors that arise during your medical procedures. And I was just wondering, how often is it that you guys get hit with lawsuits, and generally what are the outcomes?
Yeah, so I can't talk a whole lot about it for some reason, because some of those are protected data. I can talk what is publicly open. Not very common. I mean, some of this public information. So in general, not a whole lot of lawsuits that happen. But when you go back and analyze, like, who are people who sue back physician or facilities like hospital, most of the time, medical error have no significant consequence. So I'll give you an example. For example, like a resident order a medication, is it the wrong dose? Like give too much or too little of that medication? That's a medical error, right? But nothing harmful happened to the patient. Now, a smaller proportion of medical error result in harm. So a resident give too much of a medication to a patient or the wrong medication, something bad happened, but then the harm itself is very transient. Let's say they gave too much of a blood pressure medication, suddenly blood pressure dropped, but then things resolved. Now, even a smaller proportion of where there was a harm and an adverse event, smaller proportion have a permanent or lasting effect. And now even a smaller proportion of those that have a permanent effect then get sued. So what I mean is you have millions of medical error that happen in the United States. A very, very tiny fraction then get brought through litigation process, lawsuit or malpractice, because lawsuit or malpractice is a very complex process. It can take like years. It's very expensive for both parties. So then a lot of the time where things go wrong and then family want to sue the hospital or physician, a lot of those cases kind of get closed amicably what it means get closed amicably, like the physician or the hospital will meet behind closed door with the families or the patient, kind of will discuss and we'll come to some sort of a resolution. If that cannot be solved amicably, then they go to court, and which are a small number. And then a lot of those courts are public data. So for example, if you look state by state, you can tell, or you can even look at the Department of Health of each state and look at physician name and see which physician had been sued, etc.
Yeah.
Okay, got it. Thank you.
You're welcome.
Thank you.
A good way I always protect, I always say to our fellows and residents, what can protect you, I know Elias led, but what can protect an individual from lawsuit is really being kind to patient and their family. If you're kind, if you have good reports, even if medical error happened, most of the time they'll say, well, it happened, it is what it is, patient was sick anyway, and yep. Thank you for letting us know.
Yeah, proven over and over again. Just being empathetic and kind is huge and
honest. Try not to cover it up. Yeah, because if you try to cover it up and they realize you were trying to deceive them, then they'll be angry. And now, you lost trust, and medical error was lost trust. That's worst recipe. Yeah.
Yeah. Jonathan.
All right.
Hello.
Hi, Jonathan.
Hey. So, 2 questions. One's really quick. Maybe I missed it, but what are your hours like during a week? And 2, I've come across different physicians on how they deal with litigation. And I'm just curious. It seems like some are, I wouldn't say not worried, but it doesn't affect them as much. And I've come across physicians that it affects how they treat, how they interact, kind of almost like a, not fear, but just like a constant worry on your shoulder. So how do you approach that? Obviously, you're in neurology, so it's a little more critical. But just what's your approach to that?
Totally. So what's my work hour? So I work in an academic place. So that means my time is split between taking care of patient like I'm doing tonight, education, so instructing medical students, fellow didactic, and some research. I'm very fortunate enough that by being a program director, I'm in charge of the schedule as well, which of course comes with a big responsibility of being really fair to everyone. So typically we will schedule our physician 5 to 6 shifts or sometimes 4 to 6 shifts. Shifts are typically 12 hours and can be a mix of days and nights. And then afterwards, several days off. And the days off can be admixed with some administrative or didactic responsibility. For example, now I've worked 6 shifts in a row. Tomorrow I'm taking it off. I'm going diving tomorrow. I'm taking my boat out and going diving. You need a day off. And Wednesday, I have some stuff to catch up on Wednesday, administratively in my office. And then on Thursday, I'm running a series of didactic, like lecture, workshop for the emergency medicine residents on how to address neurological emergency. And then Friday, I think also I blocked it. I'm taking off on Friday, spending some time with my family. But that's give you a snapshot of what I do. And I've been taking care of patients since last Tuesday. I've been on the wards taking care of COVID patient. I worked through the weekend since last Tuesday. So today's my last day. So kind of 6 days in a row continuously. And then for the second part, Jonathan, about how do you carry that afterthought or that burden of, well, can you get sued or not? In reality, I don't look at it that way, because if I think about it this way, it's going to distract me from the important part, which is taking care of the patient medically. I tried every day I take care of patient to give my best. So know about their medical condition, read about their condition, get a good history and physical exam, ask as a physician, if you don't know, like specialist physician, let's say, patient has a pretty complicated infectious disease history, I may ask an infectious disease specialist to help me. They have some serious cardiac issue, I'm going to ask a specialized cardiologist to help me. So try to really practice ethically the best you can scientifically. And then if something wrong happened, I will talk to the patient, I'll be honest. And then if the patient, let's say they tell me, well, Dr. Babi, we want to sue you, we're not happy with you. I'm like, all right, well, thank you for letting me know, I'm sorry for what it is. And then, of course, I would inform our hospital lawyers, because that's why we work in a group in the hospital. And our hospital lawyer will meet with me and we'll address it. We'll review the case.
Awesome. Thank you. It's just kind of refreshing to hear. It's a good perspective.
Yeah.
You gotta just do your best every single day and know that there are lawyers out there always constantly trying to find their money, but you do the best you can. And
on both sides.
Yeah.
On both sides of the table. On that side and on your side as well. They're trying to find their job security, right?
Exactly. Well, Dr. Marc Babi, I will let you go. Thank you so much for taking some time with us tonight. I'm glad the pager was pretty quiet for you. Hopefully the residents and fellows are out there doing their best because you've trained them well. So thanks for coming on, sharing your thoughts about neurocritical care, and hopefully we'll get some future neurocritical care docs up in here in a few years.
Awesome. Brian, pleasure and my honor and privilege to be invited and to speak to this brilliant group of participants, and best of luck to all of them.